My name is Dr. Sana Sarfraz, and I am an imaging fellow at FIC Institute Cardiology in Rawalpindi. I am presenting a rare and interesting case that is titled A Stroke from the Heart, an exceptionally rare left ventricular myxoma. So my patient was a 75 years old lady. She was a known hypertensive since 8 months, and she was well controlled on medications. She had normal sinus rhythm and no other significant comorbidities. She presented with a history of sudden onset of slurred speech that resolved within 2 hours, consistent with transient ischemic attack. Her CT scan brain was performed, which was negative. Her carotid Doppler was negative, not revealing any significant vascular disease in the carotid arteries. There was no evidence of fever, no infection, malignancy, autoimmune disease, or vascular source of embolism. So there was no history of fever, as I already told you. So patient was then referred to a cardiologist in order to assess any intracardiac source of this embolic phenomena. Transthoracic echocardiography was performed that revealed a mobile pedunculated mass in the left ventricle. It was attached to the interior aspect of the basal interventricular septum, and it was extending into the mid left ventricular cavity. It was gelatinous in appearance, non-calcified, and it was present just below the left ventricular outflow tract and was not causing any obstruction. This is the transthoracic echocardiography image, parasternal long axis view, and this is demonstrating a mass. Isko start. Sorry, this is the parasternal long axis view, transthoracic echo, and it revealed a mass which is attached to the basal interventricular septum, and we can all see that it is protruding into the mid left ventricular cavity just below the LVOT. Okay, in this case, color Doppler was used, and we can see a bit of flow turbulence that was present just below the LVOT. In the next image, pulse wave Doppler was performed in apical 5-chamber view in order to assess any gradient that would have been produced across the left ventricular outflow tract because of this mass. And here you can all clearly see that minimal gradients were established across the left ventricular outflow tract, hence this mass was non-obstructive. This is a short axis view. It is again demonstrating the mass. This is the apical 4-chamber view, and here we can clearly see the gelatinous appearance of this mass attached to the basal interventricular septum. It was measured in different windows and transthoracic echo, and the maximum size that was taken was around 3 into 1.5 centimeter along the basal interventricular septum. So, after looking at all these images, these were the differential diagnoses. First of all, a mural thrombus, intracardiac tumor, myxoma, fibroelastoma, or it could have been a vegetation. Why further imaging was needed? It was needed because left ventricle is an unusual location for such a mass, and there was need for tissue characterization and for proper surgical planning if we had to proceed further. So a decision was taken to perform cardiac MRI. And cardiac MRI was performed, and the findings were that it was a pedunculated mass in the left ventricle attached to the basal interventricular septum. It was highly mobile, well perfused, and it showed heterogeneous enhancement on the early and late gadolinium enhancement images. Okay, so this is the cardiac MRI images. These are the Cine SSFP images, and we can clearly appreciate the mass, this mass, which is well localized, rounded in shape, pedunculated, attached by a stalk to the basal interventricular septum. Here we can clearly appreciate that this mass is well localized. This mass is well localized, it is round and is attached to the basal septum. This is a cine image, and cine image which clearly demonstrates that the mass is attached by a stalk. There's a stalk which is attached to the interventricular septum. We can clearly appreciate the stalk with which this mass is attached to the interventricular septum. Okay. These are the T2 weighted fat sat images that were performed, and here we can appreciate that this mass, it was not suppressed in these images. Hence, it was concluded that it cannot be a lipoma. Otherwise, it would have been suppressed in these images. So, this was clearly in favor of negating one of the differentials that could have been a lipoma. These are the first pass perfusion images. And here we can see that this mass is well perfused. So, it establishes that there is a bit of vasculature that is present in this mass. These are the T1 weighted images, and here we can appreciate this mass. This is a certain artifact, but overall this mass, it appears isointense to the rest of the myocardium. So what does isointense mean? It means that this mass has a mixture of tissues. It is heterogeneous. It favors the nature of this mass is heterogeneous, and the T1 relaxation time of this mass is the same as that of the myocardium. Hence, it appears the same as that of the myocardium, isointense. These are the early gadolinium enhancement images, and here we can see that this is the heterogeneous uptake, and this mass is of heterogeneous nature. Again, with the early gadolinium enhancement images in short axis views, here, heterogeneous nature. And these are the late gadolinium enhancement images where we can appreciate the heterogeneous nature of the mass. So we have seen the images of transthoracic echo as well as the cardiac MRI, and I also told you about the different differential diagnoses that we had in mind. So now we come to differentiating these differentials. So a thrombus, typically it favors the LV apex, and it is broad-based and is associated with regional wall motion abnormalities. The valves, they are present on the valves, they are irregular, and there is no perfusion shown by a vegetation as well as a thrombus. And fibroelastoma was also one of the differentials, but the difference between a myxoma and fibroelastoma is that myxoma favors the heart chambers, whereas the fibroelastoma, they favor the valvular endocardium. The myxoma, they are well localized, round, but fibroelastomas are frond-like and they are very mobile. So after looking at these images, a diagnosis of myxoma was very much likely, and the final diagnosis was left ventricular myxoma, and this was the cause of the embolic neurological deficit in the patient. And urgently the patient was referred to the surgical side so that further prevention for recurrent strokes could be done. So in the end, what we conclude is that majority of the myxomas, they arise in the left atrium. The 70 to 80% of the cases are present in the left atrium, 10 to 20% in the right, and only 2 to 4% of the cases are present in the left ventricle. So it is an uncommon sight. And the septal attachment is exceptional, and neurological presentation without any cardiac symptoms can present with such a mass. and they can present as stroke, and echo is very important is a very important first line investigation, and MRI is essential for the confirmation of this. And this proves that multimodality imaging is very important in such cases, and it improves the outcomes in the patient and should be done. Thank you.